And welcome to John Gray from the Matter, and also welcome back to Geraldine Byers, who's nurse consultant for both RVH and the Matter. John, you're very welcome, and Geraldine. And again, the same format as before. We will give you 5 minutes to make an opening statement, and then there'll be questions. So please fire away.
Mr. Allenby, Professor Hunt, Ms. Reynolds, it is important to understand the important role of the Mater Hospital Emergency Department in the context of the Belfast Trust. As I am sure you're aware, the Mater ED manages approximately a third of all ED attendances and medical admissions within the Belfast Trust. The underlying philosophy of the entire Mater ED team, medical, nursing, admin and support staff, is to ensure safety, quality, timely and compassionate care, and I would like to pay tribute to them for their hard work, dedication and resilience. The themes being explored by your inquiry are important to patients, their families and also to healthcare staff. The Mater ED will welcome any feedback that will improve the patient journey while attending our department. We are all conscious of the current challenges faced within emergency and unscheduled care, both nationally and locally. These challenges also exist in the Mater ED. Personally, I believe the Mater ED, alongside the RVH ED and the wider Belfast Trust, is committed to ensuring that where necessary, current processes are reviewed, barriers overcome and changes initiated to provide optimum care for all patients.
Okay, thank you. My first question is really whether you think the issues that were raised in the report of the significant incident by the RQIA in the Royal, and I'm thinking now across the piece in terms of issues of care and treatment, but moving on to issues of supportive staff, culture issues, concerns about cultural bullying, and a number of other issues. Are those issues that had resonance for the Mater? And if not, what are the things that are different in the Mater from the Royal, and why do you think things are different?
I think the Belfast Trust EDs face similar pressure. I think that is to do with inflow factors in the department and then outflow from the department. And I think the Mater ED faces those issues, as does the Royal. I think you have to understand that the emergency department is sort of a central cog in unscheduled care, and attached to that are many other cogs, other specialties, diagnostics, and for that whole apparatus to work well, all of the cogs need to turn well and efficiently, and sometimes both in the Royal and in the Mater site, issues can arrive if the whole system is not going as well as it might do. So I think in that regard, that issue would be the same for the Royal and for the Mater. As regard to culture of bullying, I do not believe there's any culture of bullying within the Mater. I am clinical lead on the Mater site. I've worked there for 5 years. My medical staff, who I'm most responsible for, both middle grade and junior, I meet with regularly. I operate deliberately a very open door, low authority gradient style of management so that people can come and speak to me, and no one has ever approached me about that. Also, being a smaller hospital, I have very good relations with nursing staff, both in the ED and beyond, and nothing has been brought to my attention on that. And also even meeting union representatives, as I do, because they work in the hospital under different roles. No one has said to me that they have issues or concerns about bullying of staff.
And on the issue of support of staff more broadly and involvement of staff in in decision making, is that an issue for the Mater as well as the RVH, or are things again different in the Mater?
I hold a clinical lead position within the Mater ED. Mm-hmm. So part of my role is to provide managerial and clinical support for our middle grade doctors and our junior doctors. And I think on the matter site that works well, both formally and informally. There would be a feeling probably among medical and nursing staff that there's been slightly less engagement of managers at some times on the matter site. We see approximately a third of the patients, and therefore you might argue that we should maybe get a third of the manager's time. Of course, there's more than one perspective to any argument. The matter, even when it has had its difficulties, has continued to perform relatively well, and so perhaps managers have then focused their attentions where they thought they most needed to. But the matter is committed to improving patient experience, delivering high quality care, and if we could ever, have more input from our managers, then we would, of course, welcome that at every opportunity, because we want the service within the matter and within Belfast, to be as good as it can be for every patient.
I wonder, and Paul in an earlier session had asked the question of, well, if you see a management issue in your clinical position, who do you go to? How can you get that resolved? Does being in the matter and in terms of your access to management with its less public focus make a difference to that? Or how does that work in practice if you felt something was happening that you thought was actually needed a management solution rather than a clinical solution, how would you make sure that happened in practice?
Okay. Well, management issues can come to me really through a number of routes. We meet regularly with all our junior staff for teaching every Wednesday, and as part of that, there's an informal part of that where we say, have you issues? Is there anything you need us as your consultant colleagues to address? We have weekly management meetings where middle grade staff or nursing staff who are permanent staff can bring issues to that management meeting. Geraldine would be at some of those meetings, service manager would be at others. So often the issue is allocated to whoever it's most appropriate to allocate it to. And we do speak to managers regularly. I think with previous clinical directors, they have struggled maybe to be on the matter site as much as we would have liked them to be. I'm encouraged that John Maxwell, our new CD, is splitting his time between both emergency departments, because that therefore lets him experience the issues that are happening on the matter, and also gives us very directly the opportunity to pass any issues to him. There are monthly management meetings across the whole trust. So both EDs meet on a monthly basis, and some of the issues that have arisen on one site, relevant to another, or just relevant to one site, can be discussed. So I think that there's a weekly and monthly structure for meeting with managers. I have their mobile phone and they have my mobile phone, and I speak to people when I need to. I try to solve what I can and then take up the chain of command things that I think I need senior manager input on. So for that reason, I suppose they may perceive me as only bringing troubles to them for them to help solve. And it would be good in any relationship to meet sometimes people more regularly, so that we're not just meeting around issues that are difficult. Conversely, however, as managers have, when the performance has been good, have cascaded down, thanks that has been shared with staff. So by all those routes, formal, informal, email, and telephone conversations, people can be engaged with management.
I suppose what interests me, from my own experience, that the informal nature of communication is very useful, but you're quite right. It does lead to a situation where you only tend to ring up when there's something gone very badly wrong, or quite radically wrong, and needs. Whereas that kind of greater engagement and greater meeting means you build up a very different relationship, and it does mean often small issues can get dealt with before they become big issues. So I wonder what the ramifications and you've said you've got a better engagement now with the new clinical director. What were the ramifications of not having the kind of level of engagement you would have liked in kind of earlier time when you were in your own role? What are the kind of things that, if you like, you look back on and think, oh, we could have sorted X if we'd had a kind of more structured environment?
The challenges to emergency medicine are the same across
Sure.
the country. So I may take an issue of staffing to my manager, as I do, and sometimes it's possible to sort it. And sometimes, even when every option is explored, it hasn't been possible to sort it, even in terms of relocating staff or whatsoever. So I think that, you know, there aren't always issues that can be solved, even if you meet. There have been national issues that are difficult to solve, meeting with managers. There are some other ones where I think we could have moved ahead at a lean process. We talked about having a patient tracker, you know, more than a year ago, and this is now being implemented, and I think it will be good for our patients and good for flow in the department. I have, with previous CDs and managers who are no longer in post, I raised the issue of trying to get an additional staff grade type doctor, and it seems now that this is moving ahead. So I've been in the trust 5 years, and I would be hopeful that we are moving in a new direction, in a positive way.
Okay, thank you.
I was just going to say as well, I think there is a recognition that there hasn't been as much management present on the Matter site as that there could be, and I think the success in our new ways of working has to take that into consideration, because the Matter Hospital is an important part of the flow of patients, and it's imperative that that's taken into consideration. The other thing I suppose that is different on the Matter site from the Royal is that the good working relationships between the ED team and the other teams within the hospital. And that's not to say that in the Royal it's bad, but it's a smaller group of individuals that you're trying to work with, so that makes it much easier, it's much less complex. I think too, with raising concerns, as John says, you know, one of the positive things about ED is that we work well as a team, and I think that we do have structures in place to try and ensure that any issues are raised, and that there's an opportunity for staff to do that, with there being a sister in charge of every shift, the consultant presence on the floor as well, making sure that they're accessible if staff do have any concerns. We do have joint ventures between the two sites. We endeavour to deliver one service over two sites, and if there are any service developments, we involve staff from both departments as well.
Okay, and that brings me, I think, to my final question, which is how does the movement of patients from emergency department in the Matter to the Royal, or admissions to the reverse from emergency to the Matter, how does that work in practice? How seamless is it? And if there are pressure points, where are they?
I think in my experience, given the bigger bed pool, both the City and the Royal, the flow of patients tends to be out of the Matter ED to either the City or sometimes the Royal. There are patients who have had procedures done, for example, primary PCI for people who have had heart attacks, who may have their intervention done in the Royal and then come back into the Matter cardiology unit. But that's not a patient from the Royal ED coming into the Matter inpatient bed. It's from a procedure in the Royal into a Matter bed. There are specialties on other sites that are not present on the Matter site. So acute surgery now, patients with acute surgical problems are transferred from the Matter ED to the emergency surgical unit within the Royal. That has been in place for some time. There were teething issues associated with that, and over a period of time we've engaged with managers, and I am now more content that we have really better processes in place to ensure patients are reviewed an appropriate way if there's any delay in transferring them from the Mater ED to the Royal.
Can you tell us a little bit what the teething problems were and how you've overcome them in practice, just that process?
I think this is an example of where the ED interacts with another specialty. So that's the ED's interaction with surgery, and it's surgery on another site. So we had to meet with the relevant managers, both ED and surgery. We had to meet with ED clinicians and surgical clinicians to look at what would be a safe and practical solution to having patients reviewed if their transfer out of the Mater ED wasn't as quick as we would like it to be. So it's about meetings, it's about talking to people as individuals and the roles they hold, and it's about working together creatively to get a solution that first and foremost works for the patient and provides safety and good care, and then beyond that, works for the trust.
Okay, thank you. I shall pass you to Marion.
Good afternoon.
I can never get this right. In terms of participation, the first part of the question relates to how you support doctors in their communication with patients, both about the treatment they receive and also if there's a threat to their survival. Second part of it is how are clinicians involved in trust planning to improve emergency care? And can you give any suggestions as to how you feel that could be improved in the future?
Communication is vital in healthcare. All of us at some time in our lives are recipients of healthcare, and those of us who work in ED also try and provide healthcare to patients. And we know communication is very important. And that's addressed, I think, really in a number of ways. First of all, partly through teaching and training. I think junior doctors now have a greater emphasis on communication skills than was present more than a decade ago when I was at their stage, and I think that's good. Certainly within the Belfast Trust Emergency Department, in some specific areas with some specific groups, such as mental health, we have an agreed training programme, and as part of that, we bring in a user to share with our doctors their experience about what works, what doesn't. So I think getting the user voice, can be important. I think as well, another good thing about the process of revalidation is that for staff such as myself or permanent ED staff, we have to, as part of our revalidation process, give questionnaires to patients. They can fill in, comment on our style, our communication, our professionalism, and those are not returned to us, those are returned independently to somebody else, and then we get a summary of that. So I think as doctors now, we are learning and reflecting on what our patients say about us.
In terms of letting people know that their condition might have survival implications for junior doctors or mid-grade doctors, are you confident that they're able to give that information to patients?
I think patients who have a threat to survival, I would you might consider in two groups. The first is someone who is acutely unwell with a sudden life-threatening illness, okay, or somebody who is acutely unwell on top of multiple comorbidities and moving towards the end of their life. The other separate group of patients we sometimes have to communicate with are people who have something dramatic discovered on an ED investigation, most commonly a cancer, that can be a threat to their life. And I think, hopefully, often junior doctors, the very junior doctors, are not left alone speaking to the relatives of someone who is critically ill. That should be a job shared by middle grade and consultant staff, so that for that patient and for that family, the communication and information can be as clear as it is. The other group who have something turned up in an emergency department, we would, I think our juniors in general do it well, from what I've seen, but the information that we can give at that stage is more limited and more guarded, and mostly we are advising people that something significant has turned up and that this will need further tests and investigations, and that is truthful and often the case.
And going on to how clinicians are involved in planning in the trust, and any ideas for improving it in the future?
Yeah, try again, or shall I just?
You go ahead.
The question, I know you've got
Yes.
it, John, it was just for how are clinicians involved in the planning of services, and can that be improved?
I think the trust has opened up sort of new work streams that are going to involve ED clinicians sitting down with other groups to look at a whole range and aspects of unscheduled care, and I think that's a very worthwhile thing to do. I think that's an expansion of some of the things that have already happened. I mean, for example, myself and Geraldine in mental health have had a meeting regularly with mental health clinicians, mental health managers, looking around the experience, both good and bad, of patients within the ED, and I think over a number of years we have sorted a good number of issues, and as in any organisation and for any patient experience, that there are still issues to be sorted. But as these come up, our staff flag them up to us, and we sit down on a case-by-case basis and see what the learning is for that patient, or for the patient who might present similarly in the future. So I think again, I come back to the central need for engagement of the ED team with other specialties. If you come to the ED with a fracture, that can be identified. You can get pain relief, you can get treatment, but if it needs specialist onward care, then we need to be engaged with our orthopaedic colleagues so that patient can move out of the ED into the right stream of care for that patient.
I was just going to add as well the question in relation to the communication. I think that one of the other important factors is about role modelling appropriate behaviour when communicating with patients and families. A lot of our junior doctors rotate through our departments, and it's important that the permanent medical and nursing staff, role model appropriate behaviour as well. I think it's imperative that the clinicians are involved in planning about emergency services, and especially these new work streams. The Mater site, because it has the added step of transferring patients to other sites, it's essential that clinicians from the Mater are involved in those discussions as well.
I think just picking up on Geraldine's point, that's very useful. I mean, I emphasise to our juniors at their induction that the most important person in the emergency department is the patient, and I also emphasise to them that over the course of their time they may meet several elderly ladies who have confusion, but for the lady who's in front of them right now, that is somebody's mum of 40 or 50 years duration, and that communicating both with the patient and with their family is vital in that encounter.
Okay. I'll now pass you to Paul.
Thanks very much. Thanks very much for your comments and for your time this afternoon. Firstly, the serious adverse incidents, and I'm just trying to get a sense of how they're perceived and to what degree they're working well or whatever. So we have this process of serious adverse incidents, and This may lead to learning letters from the board, as you know, and I'd be interested to know your professional view about this process. Is it something that you find really helpful and constructive, or is it something that has led to helpful change, or is it not as dynamic as you would have wished? I'd be interested to know what you think.
I think healthcare nationally and internationally has learnt from the airline industry, which has been excellent at making sure all adverse events of any nature are logged and reflected on. And the SAI process is our most extreme end of that for events that are serious and adverse. I certainly support it. I think for two reasons. I think if an adverse event has occurred, then the individual or their family have a right to know from healthcare professionals what went wrong, and perhaps need some assurance that that change will be implemented so that it will not occur for any other individual. And I think, for healthcare in general, if something sudden or unforeseen happens, then that learning needs to be disseminated so that it doesn't occur somewhere else. So sometimes it can be, a piece of equipment that can become blocked that was never foreseen, and that can then be disseminated to all teams who might be using that bit of equipment. So SAIs, I think, are very important. They are for the most serious events. I think as well we need to, and I think we are beginning to look at less serious events and log those more frequently and more regularly. And the SCA that was alluded to earlier, it can be for that category. It can be the initial look at something very serious that's going to go on to become an SAI, but it can equally be a look at something that wouldn't constitute an SAI, but there is still, learning for the department, for the organisation, that can be captured and shared. Doctors, junior doctors come and go in emergency departments, consultants, some middle grade staff and nurses stay. So I think one of the challenges for us is we can feed back an SAI to one group of doctors, but we need to learn and begin to establish how we're going to cascade that consistently to the next group of doctors so that those lessons are learned. Sometimes that's done through changing trust protocols. Sometimes it's done through changing the manuals that we give to junior doctors. But actually making sure the learning persists, is key.
I was going to add just to that, as John says, SAIs, that's the one end of the spectrum. We do encourage staff to report incidents because it's important that we learn from less serious incidents and look at the patterns of those and look at the trends, because we want to avoid SAIs if we can, and having a better understanding of the less serious incidents will help us hopefully to prevent incidents getting to that stage. So it's important that we have an understanding of the less serious incidents, because there are near misses, there are warnings, and we need to ensure that we have an understanding of those as well.
Thank you. A second question, if I may. From the human rights perspective, accountability is really, really important. And one could say that the serious adverse incidents, that process is a sort of accountability. Accountability doesn't just mean judicial accountability. There are lots of different forms of accountability. And from the human rights point of view, these various forms of accountability are really important. And I think most human rights advocates would say that one component of an accountability process needs to be independent. There is a role for sort of peer review, mutual accountability. That's really important too. But an additional component that the record suggests could be very important is some independent voice. And I don't just mean a civil society, though that's terribly important. I mean some sort of institutionalized independent voice, like an ombudsman or a human rights commission or whatever it might be, a health ombudsman. Now in Northern Ireland, one organisation that sort of plays that role is the RQIA. And I'd be interested to know, if you don't wish to answer, that's fine, but I'd be interested to know if you have any reflections on the RQIA and how important it is, or how it might be improved, or and one reason why I ask is that, as we know, in CQC is the sort of equivalent to RQIA, but in England and Wales, and CQC is going through a rough time at the moment. And I'm just trying to get a sense of whether or not the RQIA is seen as a legitimate voice with authority.
I mean, accountability is important. The public need to be assured that if something is looked into, that it has been thoroughly looked into, and also that it's been independently looked into. I think within SAIs, you know, I've been involved in a few, and in those, the events have been looked at independently. So, for example, it was something that's happened, say, on the Matter site would be looked at first of all by somebody from the Royal site, but then beyond that, another ED consultant in Northern Ireland has been asked to look at the clinical documentation and give their opinion, and even beyond that, then the trust have sought, you know, a completely independent person to review the events. So I think when events arise that do need independent investigation, we are doing that, and the structure's there, and that's great. I think the RQIA and the Ombudsman also, for complaints, you know, do fulfil you know, a useful function. The public need to be confident that someone outside of what they might perceive as being in the immediate healthcare community, you know, will look at events or experiences if that's necessary. And I don't think anybody has any concern about the RQIA's role or the Ombudsman's role.
I think it's essential that we have an independent body regulating us because, you know, again, as John says, to give assurance to the public. They do challenge us, and it does put pressure on us as clinicians and managers. However, it's an essential element of healthcare, and we need to have that independence, especially in the spirit of openness and transparency. We need that.
And in terms of doctors as individuals, I mean the GMC overviews our professional activity, and that has significant numbers of lay people involved. So if any doctor's performance is ever to be looked at, it's not simply looked at by doctors, but there's an independent, non-medical component to it.
Another question, if I may. Are you involved in commissioning of emergency care services? Do your line managers come to you at the appropriate time in the cycle of commissioning and sit down with you and say, you know, how can we deal with this?
No, I'm not. I mean, John Maxwell would be one of my line managers, and then there's line management above him. My managerial and leadership role is based essentially within the Matter ED, both to represent the Matter and also to liaise with people in the management structure. So I am not involved in any commissioning of services, no.
I would just say that I am, to a degree, probably indirectly, I would contribute to business cases, especially for the like of nurse staffing.
Contribute to, sorry Geraldine, I can't hear.
Business cases, especially for nurse staffing, and that would be presented to commissioners. So I suppose in an indirect way, I wouldn't be presenting to commissioners myself directly, but to a degree, yes. But again, there's always potential for more involvement.
You'd welcome that, would you? You'd welcome
yes,
more
I think
involvement.
it's important. I think it's important for commissioners to understand, you know, more of about service delivery from clinical staff, because we have the understanding and we have the knowledge to articulate that. And I think it's probably a partnership approach with our management staff, but having clinical staff there as well.
So
In the accountability reviews
Mm-hmm.
that you have
Yeah.
with that give you an opportunity to bring in issues for the Commissioner to take account of?
Well, we wouldn't. I mean, we would contribute to the accountability reviews for our area, but again, we wouldn't be presenting directly to commissioners. It would be our managers would do that. But we would obviously have to account for our specific areas and contribute to that review.
But there is a feedback loop.
Yes.
Sorry. Apparently I'm too relaxed. I should lean forward.
No, you're fine.
But I'm just trying to establish there is a feedback loop
Yes.
between provider to the commissioning
Yes.
board. Thank you.
It's a really big question, and it might be that you need to reflect on it, and if you decline to answer, that's fine, okay? It really is fine. But as you know, Geraldine, when we were talking earlier, from the human rights point of view, this idea of participation is really important, and we've talked quite a lot about it in the last 40 minutes. And there are different elements to participation from the human rights point of view. There's patient participation so far as possible, and there's public participation so far as possible, and there's health professional participation so far as possible. And we shouldn't be too romantic about participation. It's a really difficult concept and difficult to put in practice. But some would say that in recent years, some would say at least in recent years, that the health system in Northern Ireland has been a bit top-down rather than bottom-up. And I wonder whether you agree with that or not. I'd wonder whether or not you have any suggestions on how the ED and the health system within which ED is located could be more participatory, whilst recognising, of course, there's the minister and there's the chief medical officer and so forth and so on, so there's going to be some point where these two, the bottom up and the top down, meet, right? And that's part of the democratic process. But I'm interested to know, given all your experience, whether or not you have any thoughts about how to deepen the bottom-up participation within a health system, with particular reference, of course, to ED.
I think we have to give our staff the opportunity to have their voices heard by our senior management team. I'll start talking about staff and then I'll talk about patients and the public. I know that there are structures within the emergency departments, staff meetings, management meetings, and issues that are raised via these are then passed to the management team. But it's equally important that staff have the assurance that we're doing that on their behalf. With regards to service development, again, as I said before, it's essential that frontline staff are involved in any future developments, because we see firsthand the types of patients who are coming through the door. We see firsthand what the challenges are and how improvements can be made to the service. In ED as well, we really struggled to try and get a handle on our, what our patients want, what our patients think of us, other than the traditional complaints procedure. So I think that we welcome the 10,000 Voices project, because this is for the first time. This has given us a real insight as to real patient stories, and that's an excellent way for us to hear what our patients think of the service that we're providing for them. We need to learn from that. We need to be creative as to how we get more participation from our patients and our public to help them inform us of what they want. It's a challenge, as I say, for A&E because of the fact, or emergency care, because of the fact that we have such a disparate population who comes through our doors. There's no specific age range, there's no specific demographic. So we struggle with that, but I think that the 10,000 Voices hopefully is the start of a new process for us to get more engagement with our patient population.
I think you're right. I mean, it's always good to get the experience of more people, because it gives you a more rounded view of the service, its strengths and its weaknesses, and having the patients and the public and health professionals involved ensures that sort of look at something in the round. I think it depends on how on the topic that you might be approaching. For something like zero tolerance of abuse of ED staff, having a focus group of experienced ED staff who've lived through a lot of experiences, might actually help inform very senior decision makers who are drafting legislation. And I don't know if that sort of focus group approach has taken part around specific issues. Occasionally, I think as clinicians, we might feel strongly about certain issues, and we can pass them to our line managers and into the management structure. And maybe, for some of those issues, a different approach, maybe the ability to email or send some document, to a recognised body, might help, allow what some of the things have been an important issue to be looked at.
Okay. John and Geraldine, thank you. The same offer as to all. If you'd like to put any kind of submission in writing, or if you feel that there are additional evidence you'd like to give to us, that would be very welcome. And I'd just like to thank you very much for coming along this afternoon, and in your case, Geraldine, for doing a double shift. Thank you.